Good afternoon, everyone. Thank you for joining us. Today, we are joined by Nicole Thorell from Wintergreen. She is going to talk about chronic care management within the critical access hospital setting. We are a smaller group, so please feel free to unmute your lines or put something in the chat. I will be watching for any questions. If you're watching this recording and have any questions, please feel free to email me and I can place you in touch with Nicole. With that said, Nicole, I will turn it over to you.
Thanks, Laura. Thanks for joining today. I'm excited to talk to you all about general care management and chronic care management specifically. Here are our objectives for today. We're going to talk about primary care in relation to the current U.S. healthcare system, talk a little bit about chronic care management, its components, the benefits to patients and clinic, discuss billing and reimbursement, and then end up with talking about how to implement a chronic care management in your clinic. So the U.S. healthcare system is really failing many Americans when it comes to focusing on primary care and prevention. This visual really depicts the amount that the U.S. healthcare system is spending on hospital care. This is largely the failure is because our healthcare system is focusing on hospital care and not on individuals maintaining health through prevention and continuous primary care and encouraging them to seek sick care during disease prevention, which is demonstrated here. Since the 1980s, primary care in the U.S. has been recognized as the backbone of healthcare, providing comprehensive care to complex patients, coordinating care among specialists, and rendering preventative services to contain costs and improve clinical outcomes. There are 6 mechanisms of primary care that may account for the beneficial impact on population health, and they are greater access to needed services, better quality of care, an increased focus on prevention and well care, early management of health populations, the cumulative effects of primary care delivery and the characteristics it provides, and the role of primary care in reducing unnecessary and potentially harmful specialist care. I'm going to talk a little bit about chronic care management and general care management in specific. So this is just a patient case and really describes the importance of chronic care management. In one of my roles, we saw a chronically disabled female, and in the past 12 months, she had had 6 hospitalizations and too many ED visits to count. Upon arrival to the hospital, her current weight was 598 pounds, and she was unable to care for herself at home. She had multiple chronic conditions, multiple comorbidities, and was really failing at home. Her goal when being admitted to the chronic care program was to attend her child's graduation the following year. With the chronic care management coordination provided by the care coordination in the clinic and her primary care provider, this patient lost 127 pounds. During her time in the program, she had no hospitalizations and she was able to attend her child's graduation, which was her goal. So this is just a great depiction of the benefits of chronic care management and the great care it can provide. So to be eligible to be in a chronic care management program, patients must have 2 or more chronic conditions that are expected to last at least 12 months or until the patient's death or place them at a significant risk for exacerbation, decompensation, or hospitalization. Some of the key components of a chronic care management for patients with 2 or more chronic conditions are it offers a multitude of benefits for patients, including improved health outcomes, enhanced patient engagement and empowerment, reduced hospitalization and emergency department visits, increased medication adherence, increased coordination of care, and comprehensive care planning. Providers can receive payment when providing at least 20 minutes of qualifying activities per month. Chronic care management plays a crucial role in improving patient outcomes, enhancing the patient experience, and reducing healthcare costs by providing comprehensive, coordinated, and patient-centered care for individuals with chronic conditions. So some examples of qualifying services that are usually included in that 20 minutes per month are communication with the patient and the caregiver regarding questions, updating the care plan, reviewing medication adherence and compliance, ensuring follow-up visits are scheduled, and that loop closure for any exams results in coordination with those specialists. going to just discuss a little bit of Medicare's role when it comes to chronic care management and general care management in general. So care management services are an example of how primary care can support a goal of improved patient outcomes. There are many deferred allowable care management services that are payable through Medicare, including transitional care management, chronic care management that we're discussing today, principal care management, principal illness navigation, general behavioral health integration, and the psychiatric collaborative care model. So in January of 2024, Medicare added 4 additional buckets to their general care management, which are remote physiological monitoring, remote therapeutic monitoring, community health integration, and physical illness navigation. GO511 is the HCPCS code for rural health clinics covering general care management. Previously, GO511 could only be billed for 1 care management service per patient per month. But in January of 2024, CMS expanded access to care by allowing federally qualified health centers and rural health clinics to bill GO511 once for each qualified service per month, as long as the requirements were met for each separate code and not duplicated. The one exception to this is with RPM and RTM. These may not be billed together even when multiple devices are provided to a patient. CMS explains that the services associated with all of the medical devices can be billed by only one practitioner, only once per month per 30-day period, and only when at least 16 days of data are collected. Practitioners may bill RPM or RTM concurrently with the other general care management services that are listed on this slide. So this is an example of a general care management case study. So there's a 78-year-old male with a past medical history of congestive heart failure. He has a history of diabetes mellitus type 2. He has high cholesterol and hypertension. He's had 6 ED visits and 3 hospitalizations in the last 3 months and was discharged from the hospital this AM after having a cardiac catheterization. This patient would be eligible for multiple general care management codes under Medicare's allowable services. Due to his recent hospitalization and discharge, he would be eligible for that transitional care management with a phone call within 2 business days of discharge and the follow-up visit with his primary care provider. Having 2 or more chronic conditions, he would be eligible for chronic care management and that loop closure, providing care with a specialist. With his history of congestive heart failure and diabetes and hypertension, he would also be eligible for that remote patient monitoring, which may be an in-home scale where we're monitoring daily weights. It could be a glucometer that's transmitting his blood sugars back to his primary care office, or even a blood pressure cuff monitor where it was transmitting his blood pressure readings on a daily basis. So this slide kind of talks about your CCM billing codes and reimbursements. So practitioners can bill for CCM for a calendar month when at least 20 minutes of non-face-to-face clinical staff time directed by a physician or other qualified healthcare professional is spent on care coordination for a Medicare patient with multiple chronic conditions. This time may be spent on activities to manage and coordinate care for the eligible Medicare and dual eligible beneficiaries. These are the different codes that are chronic care management codes. The minimum number of minutes that need to be provided to bill chronic care management is 20, but there are additional codes for additional time spent for those patients throughout the month. So when we talk about the benefits of chronic care management, there are patient benefits and then there are provider and practice benefits. When we look at those patient benefits, there are many of them that revolve around that continuous relationship with their chosen care team. Primary care is really that trusted relationship with the patient. And so chronic care management really helps to build and expand on that trusted relationship. It's that 24/7 access to health information. And this can be established in many ways. It may be through your local critical access hospital, if you are a rural health clinic that are attached to a hospital that has access to your electronic health records. It could be, being able to call the nursing department after hours. It may be through an after hours offering answering service. But there's many ways to reach that 24/7 access. But having that as a chronic care management patient helps to build that trusted relationship. It's improved health outcomes through that coordination of care. It's ensuring that when that patient, maybe the patient we talked about earlier, follows up with his cardiologist and the cardiologist changes a medication, that primary care record is updated so that the primary care physician has the correct medications that patient is taking and is able to support that cardiologist plan of care. And really the biggest patient benefit is supporting and achieving their desired health goals. We talk a lot about patient-centered care and what that is. And so through chronic care management, you can really discuss with your patient what it is that's important to us. In that first patient case that we talked about, this individual's desired health outcome goal was to be able to walk and attend her son's graduation. And so through coordinated care and chronic care management, you can help to support that patient-centered goal. Then there's also the provider and practice benefits. So when we look at that provider side, it's really increasing that efficiency in care. So it's being able to be billed and reimbursed for that time that's spent outside of that face-to-face office visit with that patient. It's the additional loop closure with those specialists. It's going through those notes. It's updating that medication reconciliation so that when the patient does come to the office, we're not having to do a lot of that extra work that is spent sometimes updating patient records. It's decreasing those hospitalizations and ED visits. It's decreasing that operational cost because there is that additional reimbursement for the time that the support staff is spending answering patient questions, following up with patients, updating medical records, et cetera. So now we're going to talk a little bit about how you implement chronic care management in your practice. So the patient-centered medical home, or PCMH, is a care delivery model that coordinates patient care through a primary care physician. PCMH accreditation indicates that providers deliver patient-centered team-based methods, population health management, personal care management, care coordination, and consistent quality care. If you are a PCMH facility, you already have the processes in place to support a chronic care management program. If you are not a PCMH accredited facility, you still can provide a great chronic care management program through care coordination. The first step is identifying and looking at what the potential is for your program, what resources you will need, and then implementing a PDSA structural model for implementation. So let's take the next couple of minutes to discuss the steps you can take to implement a successful chronic care management program. The PDSA, or Plan, Do, Study, Act cycle, is a systematic approach to continuous improvement. For the PDSA cycle to be effective, it's important to repeat the 4 steps in a continuous loop. Success of this chronic care management implementation PDSA model can be measured by evaluating the total number of patients enrolled in your chronic care management program over the total number of patients eligible as defined by Medicare. The goal of this PDSA is to implement an effective chronic care management program through 4 PDSA cycles, which we'll discuss on the next slide. So if any of you are familiar with LilyPad, this is a PDSA cycle that will be available in LilyPad later this year on chronic care management. But the outline for the 4 PDSA cycles to implement an effective chronic care management program are chartering, training, outreach, and intervention. Chartering is the phase where you are assessing the organization's readiness to implement the program, including the collection of baseline data. An essential part of the chartering process is buy-in from leadership, whether that be your practice manager, your providers, your practice owners, or your hospital executives. The sponsorship should be explicit, focused, and documented to secure resources and establish expectations and accountabilities. The second PDSA cycle is training. In this phase, you will provide education on the requirements, including the documentation process to all staff involved. And in addition, you'll create and identify resources and standing orders that staff can utilize for patients enrolled in your chronic care management. The next cycle is outreach. In this cycle, you will develop and distribute marketing materials. The best marketing campaigns use a coordinated mix of print and digital distribution that address specific diseases and conditions, but that also promote clinic brand awareness and engagement that serves as an asset for your chronic care management program. The final cycle is intervention. Here's where you launch your first small cohort of patients into your program. You collect and monitor data to ensure all required elements are met for billing and evaluate the revenue cycle processes from coding to payment. At the end of each cycle, you will measure the effectiveness of that cycle through the ACT phase before moving to the next PDSA cycle. Once you've successfully completed the fourth cycle and final cycle, you're ready to grow your program with enrolling additional patients. So I'm sure now I went through that pretty fast. I only took up 20 minutes of your time. This is probably what your brain feels like, a bunch of information flowing back and forth and running into each other. And where do you even start? So my recommendation to you, if you are interested in starting a chronic care management program, is really find your why. Why is this important to your clinic? Why is it important to your providers? And why is it important to the patients you serve? And then start somewhere. It looks like a lot of information. It seems like a lot of hard work, but really just start somewhere. Identify why it is important to you. Maybe it be that one patient you have in your clinic who is in your emergency department all the time, is calling and leaving messages for your nurses, and is really requiring a lot of extra attention to keep well. Maybe that's your why. Maybe let's start with him. Let's enroll him into your chronic care management program. Let's coordinate his care. Let's work with him and measure his improved outcomes and use him as an example of how you could grow your program. So as I said, I went through that really fast, so I will stop and pause and see if there are any questions.
Nicole, we don't have any in the chat yet, but I just wanted to share with folks, Nicole, you were one of the newer folks at Wintergreen. Nicole comes from a vast clinical background as of recently, and you implemented a similar program at your previous facility. Is that right?
That is correct. Yep. I, in my previous role, was the chief nursing officer and director of risk and quality at a critical access hospital, and had 4 rural health clinics. So we implemented chronic care management and transitional care management into our 4 rural health clinics.
Do you have any tips or just basic advice for folks getting started?
My basic advice, I would say, is to start small. Start with one patient. Work your processes through that one patient, and then slowly expand. Once you get your processes down pat, it's really easy then to grow your program. But start small, work through your kinks, develop a really good process before you expand. My recommendation would be find that provider who can be your champion, your provider and their support staff that really are interested in chronic care management, interested in providing coordinated care, and work with them directly. To be able to start your program, because they can be your champions. They can help develop that process, and they can help tell you, okay, this didn't work. We need to do something different. Or, we found we need a standing order for diabetes. So then the care coordinators can just set that patient up every 3 months for their visit. But start small and then grow as you have things developed.
Thank you. Does anyone have any questions before we get off the line? Oh, and you have the codes in there and everything.
Yep, I will. Do you want me to send these slides to you?
Perfect. Well, if there are no questions at this time, please do not hesitate to reach out to us. If you get to a team meeting and want to get started and you're completely stumped, or which direction do we go next, please do not hesitate to reach out. Or if you're watching this recording and you have any questions, again, please don't hesitate to reach out. Nicole, thank you for your time, and everyone have a great rest of your day.
Thanks, Laura. Have a good day, everyone. Thanks for joining.